There is a woman I want you to think about right now. She was 68 years old, sharp as a tack, the kind of person who never needed to write down a birthday, never forgot a face, never lost a thought mid-sentence. Every single morning without fail, she sat at her kitchen table with a cup of coffee and worked through the crossword puzzle in pen, not pencil, because she never needed to erase. Her family called her the human encyclopedia. If you needed to know something, you called her before you reached for your phone. She remembered every anniversary, every graduation, every small detail from conversations that happened years ago. She was, by every measure, a woman in full possession of her mind. Then something changed. It did not happen overnight. It crept in slowly, the way fog rolls in before you realize you can no longer see the road. About 18 months after her doctor added a new prescription to her daily routine, her daughter called in tears. The woman who once narrated family history from memory could no longer remember what she had eaten for breakfast. She was getting confused driving home from the same grocery store she had visited every single week for 2 decades. She was asking the same question 3 times in a single conversation, and each time she asked it, she had absolutely no memory of having asked it before. Her neurologist, after a series of tests and evaluations, suspected early Alzheimer's disease. Her family began grieving her while she was still sitting at the kitchen table, still holding her pen, still trying to find the words. But here is what nobody told them. Here is the thing that changes everything, the thing that should make you set down whatever you are doing and pay close attention for the next several minutes. Her decline was not Alzheimer's. It was not inevitable. It was not a natural consequence of aging or genetics or fate. It was her medicine cabinet. When a specialist systematically reviewed every single medication she was taking and made carefully supervised changes in partnership with her physician, something remarkable happened. She started coming back. Within 4 months, she was doing the crossword again. The fog lifted. The woman her family thought they were losing walked back through the door. This is not a miracle story. This is preventable medicine. And what happened to her is happening right now, today, to millions of people who have no idea that the pills they trust are quietly stealing their minds. What you are about to hear covers the 9 most common categories of medication that research has linked to memory loss, cognitive decline, and dementia-like symptoms in older adults. These are ranked from the commonly overlooked to the most dangerous pattern that almost no doctor ever sits down and explains to their patients. Stay with this all the way to the end, because the final entry on this list is not a single medication at all. It is a hidden combination that affects an enormous number of people over the age of 65, and the odds are high that someone you love is caught inside it right now without knowing it. Before anything else, one thing must be said clearly. Nothing here is a recommendation to stop any medication without speaking to a physician first. That conversation is essential. What this is the information you need to have that conversation in the first place. You have every right to ask what is going into your body and what it is doing to your brain. Knowledge is not the danger here. Silence is. Starting at number 9, there is a medication that is sitting in millions of nightstands across the country right now. Tucked into a bathroom cabinet, tossed into a purse for the flight, considered so harmless that most people do not even think of it as a medication at all. It is sold over the counter. It is cheap. The packaging says sleep aid right on the front. It is diphenhydramine, the active ingredient in the pink and blue pills most people know simply as the allergy and nighttime sleep remedy that has been around for generations. It feels like the safest possible thing to take. And that feeling is exactly what makes it so dangerous for anyone over the age of 60. Diphenhydramine belongs to a class of drugs called anticholinergics. That word will matter more and more as this list continues, so keep it in mind. Anticholinergic drugs work by blocking a neurotransmitter called acetylcholine, which is the brain's primary chemical messenger for forming new memories, maintaining focus, and staying mentally alert. When you are young, your brain produces enough acetylcholine that blocking some of it causes only mild, temporary effects. When you are over 60, your brain is already operating on a lower baseline of this chemical. Block even more of it every night with a sleep aid, and the effects are not mild. A landmark study found that older adults using this ingredient regularly faced a substantially elevated risk of cognitive decline, with measurable changes in memory-related brain regions visible on neuroimaging. The most alarming part is how well it hides. It appears in dozens of products that are never marketed as antihistamines. Anything labeled PM, anything called nighttime relief, anything marketed as a sleep formula almost certainly contains it. For allergies, second-generation antihistamines that do not cross into the brain the same way are available and worth asking about. For sleep, there are safer paths, and some of them will come up before this is finished. Coming in at number 8 is a category of medication so commonly prescribed and so universally trusted that most people who take it have never once been told there is any reason to question it. Proton pump inhibitors, widely known as acid reflux medications, are among the most overprescribed drugs in the entire world. The problem is not only that vast numbers of people are on them, it is that they are on them indefinitely, year after year, when most of these medications were originally designed for 8 to 12 weeks of use at most. They reduce stomach acid, which sounds straightforward and beneficial. What most patients are never told is that stomach acid also performs a critical function that has nothing to do with heartburn. It extracts and absorbs vitamin B12 from food, and B12 is not a supplement you can simply skip. It is structurally essential to brain health. Deficiency in B12 produces memory impairment, depression, nerve damage, and a pattern of cognitive deterioration that is so similar to early Alzheimer's disease that the two are routinely confused, even by experienced physicians. A major study examining more than 73,000 adults over the age of 75 found that long-term users of these acid-blocking medications had a 44% higher risk of developing dementia compared to people who were not taking them, and the story goes deeper than vitamin B12. Research has also found evidence that these medications may accelerate the accumulation of the same toxic protein plaques that define Alzheimer's disease at the molecular level. We are not simply talking about a nutrient deficiency that can be corrected with a supplement. We may be talking about a direct biological pathway toward irreversible neurological damage. If you have been on these medications for years and nobody has ever tested your B12 or magnesium levels, that conversation with your doctor needs to happen soon. Number 7 on this list is one that genuinely reveals how much is left out of the average patient conversation at the average doctor's appointment. Overactive bladder is a real condition. It is embarrassing. It disrupts sleep. It affects quality of life in ways that are difficult to explain to someone who has not experienced it. So when a doctor offers a prescription and says this will help, of course you take it. What is almost never explained is that one of the most commonly prescribed bladder medications is among the strongest anticholinergic drugs in widespread clinical use. It does not limit its effects to the bladder. It crosses into the brain with remarkable ease and directly interferes with the same acetylcholine system responsible for memory and learning. Studies have shown that the hippocampus, which is the brain's primary center for filing and retrieving memories, demonstrates measurable physical shrinkage in people who use strong anticholinergic drugs long-term. Not brain fog, not confusion, actual structural change, actual loss of brain tissue. A major study published in a leading medical journal found that seniors who used this class of bladder medication for more than 1 year had a 49% higher risk of receiving a dementia diagnosis, nearly 1 in 2. And here is what is most heartbreaking about this particular entry. The early symptoms of that decline, forgetting appointments, losing words mid-sentence, misplacing objects, growing confusion about sequences and schedules, are almost universally written off as normal aging. The medication is never questioned. The good news is that newer bladder medications exist that work through an entirely different biological mechanism and carry dramatically less risk to the brain. If you or someone you love is taking medication for bladder control and has noticed changes in memory or mental clarity, that specific conversation needs to happen with a urologist or primary care physician. Number 6 brings us to a category that carries genuine complexity because these medications have genuinely helped millions of people through some of the darkest periods of their lives. Benzodiazepines, prescribed for severe anxiety, panic disorder, and sleep problems, have functioned as a lifeline for people who desperately needed one. That is real, and it matters. And the science that surrounds them in older adults must also be heard. These drugs work by amplifying a brain chemical called GABA, which is the body's natural calming signal. They are extraordinarily effective at producing short-term relief from anxiety and sleeplessness. The problem emerges when that mechanism is kept switched on not for days or weeks, but for months or years. A study tracking more than 8,000 seniors across a 6-year period found that those who used this class of medication for more than 3 months had a 51% increased risk of developing Alzheimer's disease. The risk was highest for the longer-acting versions, which accumulate in fatty tissues throughout the body, including in brain tissue, over time. The biological explanation is one of the most important things to understand about this entire category. When the brain's calming signal is artificially amplified for an extended period, the brain responds by reducing its own natural activity. Neuroplasticity, which is the brain's ability to form new connections, adapt and learn, begins to deteriorate. Memory encoding slows. The brain that was being calmed gradually loses its capacity for dynamic response. And then comes the cruelest part. When someone tries to stop, withdrawal produces rebound anxiety and insomnia that is often far more severe than the original symptoms that prompted the prescription. The drug then feels absolutely necessary, even as it is the source of the damage. It is one of the more vicious cycles in all of pharmacology. Stopping abruptly is medically dangerous and must never be attempted without physician supervision. A slow, carefully managed taper over weeks or months is the appropriate path. Alternatives, including certain non-addictive anxiety medications and behavioral therapy for insomnia, have demonstrated real effectiveness and carry none of the same long-term cognitive risk. Number 5 is the entry that will surprise the most people, and it requires careful framing before anything else is said. Statins save lives. Cardiovascular disease remains the leading cause of death in adults over 60. For many patients, these cholesterol-lowering medications are genuinely appropriate, medically necessary, and life-extending. That is not under dispute. What is under discussed is the relationship between cholesterol, statins, and the brain. Nearly 60% of the brain is composed of fat. Cholesterol is not a villain inside the skull the way it can be inside a coronary artery. It is a structural necessity. It forms the myelin sheath, which is the insulating layer around nerve fibers that allows electrical signals to travel quickly and efficiently throughout the brain. It is involved in the formation of synapses, which are the connection points between neurons where all thought, memory, and learning actually happen. Without adequate cholesterol, neurons struggle to communicate. When systemic cholesterol is aggressively lowered over many years, a threshold can be crossed where the brain simply does not have what it needs to maintain its own architecture. A regulatory agency updated its official labeling guidance on these medications more than a decade ago to include memory loss and confusion as potential side effects, a relatively rare acknowledgement that came after reviewing thousands of adverse event reports from patients. A more recent analysis found that seniors over 70 using high-dose versions of this medication for more than 3 consecutive years showed a measurable increase in mild cognitive impairment compared to non-users. The important nuance is that not all versions carry equal cognitive risk. Some formulations cross into the brain more readily than others. Research has shown that versions with less brain penetration produce significantly less cognitive impact while offering equivalent cardiovascular protection. If you are on one of these medications and you are experiencing persistent brain fog or unexplained memory changes, asking your doctor whether a different formulation might offer the same heart protection with a more favorable effect on the brain is a completely reasonable and medically informed question. Number 4 surprises people almost every time it comes up because the medication in question is frequently prescribed for conditions that have nothing to do with mental health. Amitriptyline is an older antidepressant that has been repurposed and reused across decades for nerve pain, chronic migraine prevention, fibromyalgia, and insomnia. Doctors sometimes choose it specifically because it causes sedation, using what would otherwise be a side effect as the therapeutic goal itself. Here is why that is a significant problem for any brain over 60. This particular medication has among the highest affinity for the receptor sites where acetylcholine does its memory-forming work of virtually any drug still in widespread common use. Its anticholinergic activity is more potent than many medications that were specifically engineered to work on the bladder or on allergies. A landmark study examining more than 3,400 adults aged 65 and older over a 10-year period found that high cumulative anticholinergic exposure with this medication among the top contributors was associated with a 54% greater risk of dementia, and the pattern of damage was not what most people expect. It was not concentrated at high doses. Even low, steady doses sustained over years created a significant cumulative burden on the brain. What makes this particularly troubling is the invisibility of the damage as it happens. There is rarely a dramatic moment of recognition. There is only a slow, creeping erosion. Word-finding difficulties that come and go. Problems with sequencing, with following a recipe or a set of directions. A growing inability to hold complex thoughts long enough to complete them. And almost universally, these changes get attributed to aging. The medication never gets questioned. Alternatives for nerve pain exist that carry far less anticholinergic burden. Alternatives for sleep and mood that are significantly safer for older brains are available and increasingly preferred by geriatric specialists. If someone you know has been on this medication for years and has been quietly losing cognitive ground, this connection is worth raising with their physician. Number 3 requires your full attention because what follows describes something that happens every single day in nursing homes, memory care units, and hospitals, and most families never find out that it is happening. Antipsychotic medications were developed for serious psychiatric conditions. They are powerful, brain-altering drugs with a significant and well-documented side effect profile. They are also being routinely prescribed off-label to elderly patients who are simply confused, restless, agitated, or, to put it plainly, difficult to manage. Not because these patients have psychosis, because in environments that are chronically understaffed, sedation is sometimes chosen as a management strategy rather than a medical intervention. A regulatory agency issued its strongest category of warning about this practice over a decade ago, citing an increased risk of death in elderly patients with dementia-related behaviors who were given these medications. The prescriptions continue. The neurological mechanism of the damage matters here. These drugs work primarily by suppressing dopamine, the brain chemical linked to motivation, reward, movement, and executive function. When dopamine is chronically suppressed in an aging brain, the results include flattened emotion, slowed thinking, impaired memory, and accelerated neurodegeneration. A study published in a major medical journal tracking more than 25,000 older adults found that seniors given these medications for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even if they had no prior dementia diagnosis before the medication was started. If you have a family member in a care facility, or if you yourself have been prescribed one of these medications for reasons other than a documented psychiatric condition, you are entitled to ask why it was chosen, what the plan is to stop it, and what non-pharmaceutical behavioral interventions have been attempted first. Those are not difficult questions. They are the right questions. Number 2 is one that does not get nearly enough attention, and the reason it doesn't is partly a matter of categorization. Paroxetine is classified as a selective serotonin reuptake inhibitor, the same family of antidepressants as many of the most commonly prescribed and widely trusted medications for depression and anxiety in the modern era. When people hear that category name, they assume safety, they assume modernity, they assume the cognitive risks of older medications have been left behind. For nearly every member of this drug family, that assumption is correct. Paroxetine is the exception. Unlike its chemical siblings, it carries significant anticholinergic activity. That one pharmacological difference separates it entirely from the medications it is grouped with and compared to. While other drugs in this family leave acetylcholine largely undisturbed, this one interferes with it in a way that more closely resembles the older tricyclic antidepressants that have largely been phased out of use precisely because of their cognitive effects. A comprehensive review found that elderly patients on this medication showed measurable declines in short-term memory and verbal recall within the first year of treatment, declines that were not observed in patients on comparable doses of other antidepressants in the same class. An official list maintained by a major geriatric medical society flags this medication as potentially inappropriate for older adults, specifically because of this cognitive concern. The frustrating irony is that it is frequently prescribed to older adults for anxiety and depression, the very population for which the risk is greatest. Switching to another antidepressant in the same class typically offers equivalent therapeutic benefit without the anticholinergic burden on the brain, and most patients transition successfully with careful medical supervision. Now we arrive at number 1. This is the entry that matters most. This is the thing that nobody is putting together, not doctors, not pharmacists, not families, not the patients themselves. Every medication discussed so far, taken alone, might cause only mild cognitive effects in some people. A little more forgetfulness, a little more brain fog, something easy to dismiss and easy to attribute to simply getting older. But here is what is actually happening in the real world, in real households, inside the bodies of real people you know. Older adults do not take one medication. The average person over 65 takes 4 or more prescription medications every day. Many take 6, 8, 10, or more, a combination of prescriptions, over-the-counter products, and supplements, often issued by multiple different physicians who may have incomplete visibility into each other's recommendations and who are almost certainly not calculating the combined anticholinergic load being placed on that person's brain. When several of those medications carry anticholinergic properties, they do not simply add to each other's effect. Research suggests they can multiply it. A major analysis tracking more than 280,000 older adults found that those with the highest anticholinergic burden, measured using a validated clinical scoring tool, had a 120% increased risk of developing dementia over a 10-year period. Not 20%, not 50%, 120%, double the normal risk from pills. Pills that the vast majority of those patients had never once been warned about in terms of their cumulative cognitive effect. Consider what this looks like in practice. Imagine a 70-year-old woman who takes a nighttime sleep aid every evening that contains diphenhydramine. She takes a bladder medication that is among the strongest anticholinergic drugs in common use. She was recently prescribed an older antidepressant for the nerve pain in her feet because it causes sedation, and her doctor thought it might help her sleep as well. And she takes an over-the-counter heartburn pill every morning without thinking twice about it. 3 of those 4 medications are anticholinergic. Each one, according to each separate physician who prescribed or recommended it, is appropriate and safe in isolation. Together, her anticholinergic burden score may fall in a range that clinical research associates with significant dementia risk. And not one doctor, not one pharmacist has done the math on her behalf. This is not a hypothetical scenario built for dramatic effect. This is the daily reality of millions of older adults living inside a system where specialists treat individual conditions and nobody is watching the whole person. The medical term for this is polypharmacy, and specifically anticholinergic polypharmacy, and it may be the single most underreported driver of dementia-like symptoms in the elderly population today. But there is something vital that must be said before leaving this topic, something that the medical literature supports and that real clinical experience confirms over and over again. Drug-induced cognitive decline is often reversible. When the medication burden is identified and systematically reduced under proper medical supervision, many patients experience a genuine and sometimes dramatic recovery of mental clarity. Memory returns. Personality reemerges. The fog that the family had accepted as the new permanent reality of their loved one begins to lift. The brain is not a passive organ waiting to deteriorate. It is adaptive, resilient, and capable of healing when given the right conditions to do so. The person who seemed to be disappearing was not gone. They were buried under something that could be removed. Here is what you can do. Starting this week, with no prescription and no appointment required, write down every single thing you currently take. Every prescription medication, every over-the-counter product, every supplement, sleep aid, occasional pain reliever, antacid, and allergy pill. Do not leave out the things you take only sometimes, because sometimes, taken daily for years, adds up. Then look up each item on the anticholinergic cognitive burden scale, which is a free, publicly available clinical scoring tool that assigns a risk number to medications based on their anticholinergic activity. A simple search will find it. Add up the numbers from everything on your list. What you discover may be alarming. If it is, that is useful information, not a reason to panic. Then schedule a specific kind of appointment with your primary care physician, not a regular checkup. A medication review. Use that exact phrase and tell your doctor you want to assess your anticholinergic burden. A good physician will welcome that kind of patient-led advocacy. Ask specifically about deprescribing, which is the intentional, supervised process of tapering off medications that are no longer necessary or that carry unacceptable risk relative to their benefit. It is a legitimate and growing field within geriatric medicine, and more specialists are trained in it now than ever before. If your doctor is dismissive or seems unfamiliar with the concept, seek a second opinion. You are not being difficult. You are being responsible about the only brain you will ever have. A geriatric clinical pharmacist, which is a real and specific area of specialization, can also perform a comprehensive medication review and may identify risks that a busy primary care appointment misses. The person who sat with her coffee and her pen and her crossword puzzle every morning did not have to lose those mornings. The family that spent months grieving a woman who was still sitting at the table did not have to grieve. What happened to her was not written in her genes or her destiny. It was written on a prescription pad, and it was undone by the simple act of someone finally asking the right questions. That story is not unique. It is repeating itself quietly in homes and care facilities everywhere, with different names and different medications, but the same invisible mechanism and the same heartbreaking misattribution. The difference between the people who stay lost in that fog and the people who find their way out of it is almost always the same. Someone asked why. Someone refused to accept the decline as inevitable. Someone looked at the medicine cabinet instead of looking away. Your brain is worth that kind of attention. The people you love are worth that kind of attention. The questions you have been hesitant to ask are not inconvenient. They are the most important questions you could possibly raise. Start asking them.